Okay,
Sure.
so I'm Richard Anderson. I'm one of the co-chairs of tonight's session. This is going to be on fertility preservation and three papers from that have recently been published in RBMO, presented by their fantastically eminent authors, and we're really looking forward to it. It's a great year for RBMO. It's in fact the 25th anniversary of the journal, a silver anniversary. And as to reflect that, there's going to be a silver edition published, and that's all ready to go and hit the printers any minute now. And with luck, it should be fully available online in just a couple of weeks later this month. And it's going to have all sorts of papers within it, reflecting the history of the journal and also looking forward from all sorts of eminent people. And somehow they've also invited Lara and myself to contribute to it as well. But there'll be some really good, it's going to be a collector's item in years to come, that edition. So do look out for it. It's going to be fantastic. So this is jointly with RBMO and i3 today. So thanks very much to the team for pulling this together. We're not going to have a lot of extensive bios. We want to cut to the meat of the occasion, but people's full bios are available online on the i3 website. So yeah, I'm delighted to be joined tonight by Laura Rienzi, Associate Professor at the University of Urbano, and of course a co-author here at RBMO. And she brings huge decades of experience in reproductive biology and IVF as well. So Laura, over to you to kick the ball off for the first.
Thank you, Richard, for a nice introduction. And I would like to introduce you also. So Richard Anderson is a professor of clinical reproductive science at the University of Edinburgh, Centre for Reproductive Health. We all know him. He works clinically in infertility and reproductive endocrinology, and has a great interest in both female and male infertility. But now we learned that female infertility is his preferred topic. And of course, he's also an editor here at RBMO, and I'm really, really very glad to be here with him tonight. So without further ado, I will introduce our first speaker, which is Professor Michaël Grynberg. Michael is globally recognized specialist in obstetrics and gynecology, reproductive endocrinology, infertility, and andrology. He's professor and director of reproductive medicine, fertility preservation at Antoine Béclère University Hospital. He's a founding member and current president-elected of the French Society for Fertility Preservation. He previously coordinated the ESHRE Fertility Preservation and leads the fertility section of the French College of Obstetricians and Gynecologists. He has authored 4 books and over 380 scientific works. His research focuses on efficiency, on ART efficiency, ovarian aging, and fertility preservation for medical and non-medical reasons. And this is the reason why he's here to talk about the influence of breast cancer prognosis factor on ovarian reserve and response to ovarian stimulation in fertility preservation. Michaël, the floor is yours.
Thank you, Laura. Hi, Richard. Hello, everybody. Definitely that biography is too long. But I'm very happy and honored to be with you tonight. So I think, can you just confirm the screen? My screen is shared.
Yes, we can see.
Yes, it is. Okay, perfect. That's good. Okay. So first of all, our paper has been published on the influence of breast cancer prognostic factors on ovarian reserve and response to ovarian stimulation in fertility preservation. So as you know, breast cancer is probably the most common malignancy in women, and it occurs in 5% in women before the age of 40. So there's a huge number of patients who could be candidate for fertility preservation. Indeed, this cancer has a dramatic impact on female fertility because of 2 phenomena. The first one is the physiologic decrease in ovarian reserve and natural fertility during the time frame during which the patient will not have the possibility to get naturally pregnant due to complete all the treatments. And the second one is the direct impact of chemotherapy, which is given to most of these young patients, and the impact of this chemotherapy will have an overall effect on the ovarian reserve and the oocyte quality. So for all these reasons and for the future quality of life of these women, fertility preservation should be now offered or at least discussed with all women, young women who do not having already completed their parental project. So as you know, we have several options: medical treatment, GnRH analog during the chemotherapy as an ovarian protection, oocyte or embryo cryopreservation, and ovarian tissue cryopreservation. But definitely ovarian stimulation followed by oocyte cryopreservation should represent represents the most important and the most recognized option for these young women diagnosed with breast cancer. The objective is to administer high doses of exogenous FSH to stimulate the antral follicle and to lead many of them, and as much as possible of them, to lead the pre-ovulatory stage. But this is associated with this treatment lasts 10 to 12, 15 days, which is not compatible with all malignancy, and is associated with an important increase in serum estradiol levels, which could be an issue in diseases such as breast cancer, which has a direct relation with estrogen, because estrogen are involved in the tumorigenesis. So our question was the impact of breast cancer itself on the outcomes of ovarian stimulation. And indeed, we know that this cancer has an impact on the general status of the patient. Perhaps it is not truly visible at the very early stage, but there might be some kind of hypercatabolism in these women that could have an impact, a direct impact, either on the ovarian reserve and or on the future on the ovarian stimulation outcomes. So there are many prognostic factors for breast cancer: the tumor size, the histologic type, the histologic rate, the proliferative rate, the expression of estrogen or progesterone receptor, HER2 overexpression, the stage of the tumor, the presence or absence of distant metastasis, the lymphovascular invasion, lymph node metastasis, and inflammatory carcinomas. So all these factors are prognostic factors that could also, or that might have an impact, a direct or indirect impact on the ovarian function. So the question was, do breast cancer prognostic factors influence the ovarian reserve and ovarian response to control ovarian stimulation in the context of fertility preservation? So this was a bicentric study between the two departments I was in charge between November 2015 and August 2022. More than 1,000 patients were referred for fertility preservation, and we had more or less 800 women included in the fertility preservation program. All these patients had breast cancer. So many of these patients received IVM treatment followed by oocyte cryopreservation, because during many years, oncologists didn't authorize us to stimulate the patient due to the issues with the increase of serum estradiol level, because aromatase inhibitors could not be used during the stimulation. So that's the reason why we did a lot of IVM, and we published a lot on IVM for fertility preservation as well. 94 patients had ovarian tissue cryopreservation, and 366 had ovarian stimulation followed by oocyte cryopreservation. So the total number of patients finally included in the study were 352, one before just ovarian stimulation, just before ovarian tissue cryopreservation, and all the others had only ovarian stimulation. So we studied different variables: the number of oocytes recovered, the oocyte maturation rate, the 40 index, which is the follicular output rate, which is calculated from the ratio between the number of follicles that have reached the pre-ovulatory stage between 16 and 22 millimeters in diameter, and the number of small antral follicles at the first day of the ovarian stimulation. So that is the ratio, the fourth, which is more or less an indirect marker of the follicle sensitivity to FSH. And those variables were studied according to the pathologic type, the unilateral or multifocal character of the tumor, the TNM stage, the UICC stage, the hormonal status of the tumor, HER2 status, Ki-67, the tumor grade, the presence or absence of vascular embolism, and the lymph node status. So we made different statistics with univariate and multivariate analysis, which were performed via a logistic regression model to identify the different factors that could be associated with an impaired ovarian response to FSH. And an impaired or a reduced ovarian response to stimulation was defined arbitrarily on the number with the number of metaphase 2 oocytes lower than 8, a maturation rate below 75%, and a 4 index lower than 35%. The factors associated in univariate analysis with a p-value lower than 0.1 were selected for entry into the model, except in the case of more than 20% missing data. So our results. So we analyzed 352 patients. The mean age was 33.6 years, with a mean BMI of 23.5. 20% of these patients were smokers. The 46% of these patients were newlogist. The number of follicles, the mean number of follicles was 20, and mean AMH levels were 2.7. So this is direct the reflect of the low age of the population. So when you have a look at the patient's characteristics in terms of their oncologic status, a large majority of these patients had invasive ductal carcinoma, which is the most frequent breast malignancy. Most of them had a unifocal tumor, and with no expression of HER2, 75%. Most of these patients had 2/3 of these patients had positive hormonal receptors, and these tumors were relatively aggressive with Ki-67 higher than 20% in 69% of patients. Most of these patients had either grade 1, 2, or 3, with half proportion of patients having either 1, 2, or 3 grade tumors. And for the UICC staging, which was available for 285 patients, the stage was 1-2 for a large majority of patients. So let's have a look now at the outcomes of the ovarian stimulation. Most of, well, at least 2/3 of these patients had a stimulation during the follicular phase, and with an antagonist protocol, initially without letrozole, and then we decided to apply letrozole in this patient despite the absence of authorization, because most of the world stimulate the patient with aromatase inhibitors. So we decided to shift and to stimulate our breast cancer patient with letrozole. So that's the reason why we have more or less half of patients having received letrozole or not. They had relatively high FSH starting dose, because we should produce, for most of the time it was only one single stimulation. So this is the reason why they were stimulated quite hard. The total amount of gonadotropins were around 3,000, and the duration of the stimulation was 10 days and a half. If you have a look at the number of metaphase 2 oocyte that was recovered, the mean number was 9, and the maturation rate was the mean maturation rate was 74, and the fourth rate was 30%. Okay, so now when we try to compare the number of oocyte recovered, number of mature oocyte obtained, and maturation rates, and forth, according to different prognostic factors of breast cancer, grade Ki-67, triple negative breast cancer, HER2 status, and UICC classification, we failed to see any difference among all these variables. And when we decided to perform the sub-analysis on the risk factors of producing less than 8 metaphase 2 oocytes, exactly the same, the only factors that appeared to be significantly associated with a reduction of the number of oocytes, mature oocyte recovered and frozen, was, as expected, the age of the patient and ovarian reserve markers. But there was nothing in terms of breast cancer prognostic factors. Exactly the same for maturation rates, and when we try to assess the risk factors of having a maturation rates below 75%, we failed to observe any impact of the prognostic factors of breast cancer. So the conclusion of this study was that our findings indicate that breast cancer prognostic factors do not influence ovarian reserve markers, nor the response to ovarian stimulation in the context of fertility preservation. And therefore, tumor grade, triple negative status, overexpression of HER2, and high Ki-67 should not be used to modify the fertility preservation strategy when ovarian stimulation for oocyte vitrification is considered. Thank you very much, and I'm ready to answer your question.
Thank you so much, Michaël. I think it's such an important piece work for women that are facing a breast cancer and can really have data now, but the chance to preserve oocyte by prognosis factor is really like not influencing the number of oocyte to be retrieved. So the chance to have a baby later on in life, which is really an incredible opportunity. So I just want to ask you, we have a Q&A session at the end of this webinar, but I have a question from US, from Mina Alikani, that I think is really very important. Do you have any data on the return of these patients? How many of these 350 patients are using these eggs, or do you have any idea I mean, we know from the literature,
we now have, let's say, more or less 3,000 patients having preserved fertility for breast cancer in the both departments I'm in charge in, and the return rate is less than 8%, so very, very, very low. Even many of these patients are infertile, because we know we did a couple of studies on this, but many of these patients had wanted the option to keep the possibility to get pregnant in the future, but most of these patients finally will not go for the reutilization. Some because they will get naturally pregnant, but most of these patients was not because of this, but just because they were still scared about the pregnancy. And we all know that this is not a risk factor. Pregnancy is not associated with an increased risk of recurrence or with a reduction in the survival rates, but there are still issues on this, and it's always in their mind, I think.
Yeah, I think it's a very important point, how the patient survive not only physically but also psychologically to the breast cancer. And I think more and more information, objective information we can give them, it's really very important to plan their future fertility. So thank you, Michaël. We will be back to you at the end of the session for the Q&A, but it's now time to introduce the next speaker, which is an honor for me to introduce Sarah Cascante. Sarah is an MD, is an assistant professor in the Department of Obstetric and Gynecology at NYU Langone Fertility Center. Her research interests include oocyte cryopreservation, fertility preservation, and infertility. She has presented her research at national and international conferences for more than a decade, and remains actively involved in research about oocyte cryopreservation, fertility preservation, and infertility research. And I thank you so much, Sarah, to be with us tonight. The floor is yours.
Thank you so much for having me. I'm very excited to speak to you all a little bit more about planned oocyte cryopreservation tonight. I'm affiliated with NYU Langone Fertility Center, and I have no conflicts of interest. Many women throughout the industrial world are now delaying childbearing and having fewer children, which has led to decreasing birth rates and decreased population growth throughout the developed world. The average age of childbirth now exceeds 30 years in many countries, including the US. This trend of postponing parenthood is attributed to various personal, professional, and educational, as well as financial reasons. However, for women, the decision to delay procreation is accompanied by irreversible age-related fertility decline due to decreased oocyte quality and quantity. Therefore, the choice to build a family later in life can lead to infertility, unintended childlessness, and adverse pregnancy outcomes. Fortunately, fertility preservation options have emerged to help women overcome these dire consequences. Planned oocyte cryopreservation, also known as elective egg freezing, is an accepted and widely used fertility preservation method that is undertaken as a matter of planning before infertility has materialized. Like the contraceptive pill, planned OC has led to a social revolution by offering reproductive autonomy through an increased reproductive lifespan and the ability to cryopreserve gametes without a partner. It also promotes social justice by decreasing the hurdles women face because they have a smaller reproductive window than men. The American Society for Reproductive Medicine removed the experimental label from OC in 2012 after studies demonstrated pregnancy rates and safety comparable to fresh in vitro fertilization. Since that time, usage has grown dramatically. The objective of this lecture is to provide a comprehensive update on the state of planned oocyte cryopreservation. The first birth from oocyte cryopreservation was reported by Dr. Christopher Chen in 1986. However, this was followed by a dearth of reported successes due to technical challenges. In the early 2000s, several reports of births from OC began to emerge. Some studies demonstrated comparable pregnancy rates to fresh IVF, and others showed that OC did not increase the risk of congenital anomalies or pose additional short-term health risks to offspring. In 2012, nearly 3 decades after the first birth from OC, the ASRM removed the experimental label from the technology for women facing gonatotoxic treatment, but it did not recommend planned OC at that time, reasoning that there was inadequate data on the safety, efficacy, ethics, emotional risks, and cost-effectiveness of the technology for that indication. In 2014, ASRM published information online describing how women without fertility-threatening diseases could still use OC. And in 2017, the ASRM Ethics Committee released a publication stating that planned OC was ethically permissible for women who wanted to safeguard against future infertility due to reproductive aging or other causes. The most common reason for planned OC is lack of a partner, with up to 84 to 88% of surveyed OC patients stating this motivation. Many of these planned OC patients want to be parents, but have not found the right reproductive partner and do not want to settle simply because their natural fertility window is closing. Thus, for many, the decision to postpone childbearing is circumstantial rather than truly desired or intentionally chosen. Aside from lack of a partner, common reasons for planned OC include career aspirations and workplace inflexibility, educational goals, financial security, a desire to travel, a recent end to a relationship or marriage, or simply not feeling ready to have a child. Many women also choose to cryopreserve their oocytes simply because the procedure is covered by their employers. And still others pursue planned OC due to concerns about future infertility, perhaps because they have been diagnosed with a low ovarian reserve or have a family history of infertility. Others are interested in planned OC because it can decrease the age-related pregnancy complications, such as miscarriage and chromosomal disorders. OC ultimately allows women to act as their own oocyte donors in the future, allowing them to have biological children from their younger oocytes and eliminating the need for third-party oocyte donors and their associated complexities and costs. Compared to embryo cryopreservation, OC offers several major advantages. First, it circumvents the ethical and legal concerns about embryo creation. Secondly, oocytes are the sole property of one person, as opposed to embryos, which are joint property, and thus there is no risk of a partner retracting consent for future use. It also safeguards the ability to procreate with a future partner. And lastly, OC is less expensive. One disadvantage of OC is that oocytes are less likely to survive the cryopreservation process than embryos. 80 to 90% of frozen oocytes survive, compared with more than 95% of frozen blastocysts. Oocytes are particularly susceptible to cryopreservation because they are large cells with a high water content and a low surface to volume ratio. The cryopreservation process involves the mobilization of water out of the cell and the diffusion of cryoprotectants into the cell. If ice crystals form during this process, they can pierce the cell membrane and cause cell destruction. It is important to note that the oocyte is a single large cell, so lysis of this cell is fatal to the entire oocyte. There are 2 methods of oocyte cryopreservation: slow cooling and vitrification. Slow cooling is a multi-step process that gradually reduces the oocyte's temperature with a machine. On the other hand, vitrification rapidly freezes oocytes through the use of liquid nitrogen, which transforms the oocyte into a glass-like structure. Compared to slow cooling, vitrification is associated with a lower risk of ice formation, is faster, and has higher cryosurvival and live birth rates. Importantly, studies have also demonstrated comparable live birth rates between vitrified and fresh oocytes. The ASRM now recommends vitrification over slow cooling. It's also important to note that technically skilled and trained embryologists are required to achieve high cryosurvival and live birth rates from OC. Therefore, the success from OC may differ based on which fertility center performs the cryopreservation and warming process. As OC continues to evolve, there is a need for standardization across different laboratories. There were initial concerns about the safety of cryopreservation and the toxicity of cryoprotectants. Some feared that they may alter meiotic spindle integrity, which could lead to chromosomal abnormalities. Yet studies found no difference in aneuploidy rates between fresh and frozen oocytes. Studies also found that cryopreservation does not alter gene expression. There is also no association between OC and negative obstetric outcomes, such as hypertensive disorders of pregnancy, diabetes, and preterm birth, or neonatal outcomes, such as congenital anomalies, birth weight, gestational age at birth, admission to the neonatal intensive care unit, and perinatal mortality. Long-term data is still forthcoming, but one small study that examined the growth and health of children up to the age of 30 months found no difference in those born from vitrified oocytes compared to those born from IVF treatment using fresh oocytes. Patients should be informed that the long-term effects of OC remain unknown, and we won't have this data for many years. Patients often ask if cryopreserved oocytes have an expiration date. The answer is we don't think so. To date, the longest storage period for a cryopreserved human oocyte that resulted in live birth was 14 years. Importantly, longer cryopreservation duration is not associated with cryosurvival rate or a lower chance of live birth from cryopreserved oocytes. OC usage has grown explosively in recent years. In 2009, approximately 500 women in the United States cryopreserved their oocytes. In 2021, more than 24,000 cycles were performed. The rapid growth in OC has also been seen in many other countries across the globe. When the technology first emerged, most freezers were over the age of 35. In recent years, more women under the age of 35 are preserving their fertility. This age shift is likely due to increased fertility awareness from fertility education campaigns and increased employer coverage of the technology. Despite the growing demand for planned OC, outcome data is scarce. Most oocytes remain cryopreserved not only due to the inherent time lag between OC and warming, but also due to the low utilization of cryopreserved oocytes. A 2021 study from our center that reported on women who underwent OC more than a decade prior found that only 38% of patients had returned for warming. In other words, the majority of OC patients will likely never use their oocytes. A commonly cited reason for patients not returning to use their oocytes is achieving a pregnancy without cryopreserved oocytes. Many other patients may also not return because they prefer not to be a parent without a partner. The largest United States report of warming outcomes from planned OC was published by our center in 2022. This study included 543 patients with a median age of 38 years at freeze and reported a 39% final live birth rate per patient. There were three key findings from this study. First, the final live birth rate from OC is comparable with age-matched IVF outcomes. Second, the age at OC and the number of mature oocytes warmed were predictive of live birth, but cryopreservation duration was not. And lastly, there was a 70% final live birth rate among patients who were under the age of 38 years at freeze and warmed at least 20 mature oocytes. This slide shows the final live birth rate per patients by age at OC. You can see that younger patients had higher live birth rates, with 51% of patients under the age of 38 at OC having a baby, 34% of patients aged 38 to 40 at OC having a baby, and 23% of patients over the age of 41 at OC having a baby. The optimal age for OC is not agreed upon, and there are no evidence-based guidelines. In trying to establish the optimal age for planned OC, one must consider several key points. First, younger oocytes are more likely to lead to live birth because oocyte quality and quantity both decline with age. Thus, many recommend cryopreserving oocytes before the age of 35, an age that is associated with an increased rate of fertility decline. OC at an older age requires more oocytes and often more cycles to achieve live birth rates that are comparable to those of younger women. Second, it is logical to assume that patients who cryopreserve oocytes at younger ages are less likely to need or want to use their oocytes in the future. They also tend to pay storage fees for a much longer period of time. Third, family planning is essential in deciding when and whether to undergo OC. Women who want more children and women who want to have children at older ages are more likely to need cryopreserved oocytes in the future. For example, a 32-year-old woman who wants one child in the next 2 to 3 years will most likely be able to achieve her goal without the use of cryopreserved oocytes. On the other hand, a 32-year-old woman who wants 3 children and wants to delay childbearing by 7 to 10 years will probably not be able to achieve her ideal family size without the use of fertility preservation or an oocyte donor. Lastly, it is important to consider financial constraints and insurance coverage. These factors may make OC more feasible at certain ages. Thus, the ideal age to cryopreserve oocytes, which must balance the chance of success, the likelihood of use, family planning, and finances, is likely different for each patient based on her personal family building goals and financial situation. How old is too old to freeze eggs? There are a small number of live births from planned OC at the age of 41 or greater. These include 2 live births from our center from patients who cryopreserved oocytes at the age of 43 years. However, to our knowledge, there are no live births that have been reported from planned OC at the age of 44 or greater. The live birth rate from OC at this age is likely less than 5%. Patients and providers dispute whether this low but non-zero success rate is enough to warrant the physical, emotional, and financial stress of planned OC. Some fear that patients may have unrealistically high expectations, as a survey showed that many fertility patients of advanced reproductive age overestimate their chance of conception. At our center, we typically discourage planned OC after the 45th birthday and stress the need for an adequate AMH level and follicle count in patients aged 41 to 44 years. This slide shows more data from our center. Here you can see the final live birth rate per patient broken down by both age and number of mature oocytes warmed. In all age groups, patients who warmed more mature oocytes had higher live birth rates. For example, in patients under 38 years at freeze, the live birth rate was 36% when less than 10 oocytes were warmed, compared to 70% when at least 20 oocytes were warmed. The ideal number of oocytes likely varies for each woman based on many factors, including age, ovarian reserve, desired likelihood of success, family building goals, and financial situation and insurance coverage. Therefore, the counseling must be individualized and dynamic. Ovarian reserve testing can help women understand how many oocytes to expect from each OC cycle. It is important to note that women with a low ovarian reserve and/or advanced reproductive age must be counseled that banking an ideal number of oocytes may not be feasible despite multiple cycles. Patients must understand that there is no guarantee of live birth, regardless of how young they are at OC or of how many oocytes they cryopreserve. Most oocytes do not lead to live birth, and banking oocytes cannot guarantee a future baby. This is because the process can fail at many critical junctions. The cycle can be canceled before retrieval due to low response or ovulation. Oocytes may not be cryopreserved due to immaturity. Oocytes may not survive the cryopreservation process, may not fertilize properly. Embryos may not develop to the blastocyst stage. Blastocysts may not be genetically normal, may not implant, and can result in pregnancy loss. The OC process is a war of attrition with loss of material at every step. For this reason, planned OC is not an insurance policy that is guaranteed to pay out. Rather, it is a family building option that increases the odds of a biological child later in life. This counseling point is essential to avoid false security. When do women return? The median time between planned OC and warming is approximately 4 years, and median age at warming is approximately 42 years. This is consistent with studies that show most planned OC patients desire pregnancy before their mid-40s. Preliminary data also suggests that an increased maternal age at transfer after oocyte cryopreservation does not impair live birth rates. In other words, the age of the uterus does not matter. However, larger studies are needed to support these findings, especially given that some studies have demonstrated lower pregnancy rates in donor egg recipients over the age of 40. Moreover, women who return for transfer at older ages must be counseled that having children at a later age is associated with an increased risk of adverse pregnancy outcomes, such as hypertensive disorders of pregnancy, gestational diabetes, stillbirth, preterm delivery, and fetal growth restriction. Most patients who return use their oocytes with a partner. However, at our center, approximately 1/3 ultimately choose to use donor sperm when they return their oocytes. Perhaps these women were always open to single parenthood, or perhaps cryopreserving oocytes inspired them to have children without a partner. It is important to understand that oocyte warming data is limited, with published studies having relatively small sample sizes. Additionally, many reports include cancer and infertility patients. The inclusions of patients with these medical diagnoses makes it challenging to extrapolate these outcomes to patients undergoing planned OC because they would like to become parents later in life. Most data has been published by high-volume academic fertility centers that were pioneers in OC. And most patients they report on were early egg freezers who cryopreserved their oocytes when the technology was still experimental. Therefore, results may not be generalizable to all centers performing planned OC or the current cohort of patients pursuing planned OC. Therefore, more studies from a range of center types and more recent planned OC patients are needed. The ASRM recommends that providers disclose their center's own experience with OC and success rates from OC or lack thereof to patients. And women should also be counseled that the long-term and transgenerational health effects for offspring are unknown. OC is a relatively new technology, and this information will not be available for decades. The decision to pursue planned OC is often complicated, as desires for parenthood are weighed against financial concerns, time constraints, medical fears, and even ethical dilemmas. Therefore, it is not surprising that 78% of women considering planned OC have high decisional conflict. Higher knowledge scores and consultation with an IVF specialist were associated with less decisional contact, and the time to decision is typically around 2 years. Therefore, there is a need for easily accessible information and greater decision support. Decision time is especially important given that a long delay may result in a lower oocyte yield and a reduced chance of live birth. Once patients decide to pursue planned OC, they may face anxiety related to the medical process, significant time requirement, number of oocytes retrieved, long-term outcome, or future partner or life path. One qualitative study of planned OC patients explained that the process was shaped by fears of running out of time to conform a conventional family, difficulties in finding a partner, and concerns about panic partnering, together with a desire to avoid future regrets and blame. This study highlights the importance of offering psychological services to planned OC patients. Despite the stress of the process, the vast majority of surveyed OC patients said they would be happy they froze eggs even if they never used them. Most felt empowered by the process and explained that OC gave them a sense of increased control over their reproductive health and planning. Factors associated with reduced decision regret included perceived adequacy of information, perceived emotional support, higher patient estimated probability of live birth, and a greater emphasis on future parenthood. In conclusion, planned OC can empower women with reproductive autonomy by allowing them to postpone childbearing while maintaining the option of having a biological child in the future. The use of this technology is dramatically increasing, but it is still relatively new and many questions remain. Patients must receive accurate and comprehensive counseling about the benefits, risks, success rates, and uncertainties of this new technology so that they can achieve their family building goals. Based on current evidence, cryopreserving at least 20 mature oocytes at the age of under 38 years provides a 70% chance of at least one live birth. Thank you for listening, and I would like to thank the entire team at NYU Langone Fertility Center. I am so grateful to work with such an astounding group of people.
Thank you very much indeed, Sarah. Fantastic. And a really great comprehensive review and highlighting really the many complexities and challenges in what might potentially be perceived as a relatively simple decision. I thought it was great that you highlighted how important it is to get across that this isn't an insurance policy. It's just increasing your odds, isn't it? So that was really, really nice to see such a considered presentation. We're going to have a full discussion at the end, but just can I ask you one question? How do you look after women who end up having a really disappointing egg retrieval stimulation cycle, end up with just a couple of eggs, and it doesn't go well? What support can you offer them?
It's a really good question. I think, first, when they come in for the initial consult, if they're a patient who you're worried may not have a good outcome, if they have a low AMH or a low antral follicle count, or if they tend to be of an older age, that's something that I talk with them about up front. I say, likely I'm expecting a small number of eggs. Likely it's going to be recommended to do more than one cycle. How do you feel about that? Just so that, going into the process, they have the proper expectations. But then, of course, there's also sometimes unexpected cases where you get less than you had thought you initially would, or less that you counsel them that they should expect. That's always a hard call to make and always a difficult discussion with the patient. I think it kind of is talking to them about how they felt going through the process, whether they would like to consider a second cycle, what changes we could potentially make for a second cycle, but also explaining that the outcome from a second cycle may not be better and it may be worse, even if we make changes to the protocol.
Great. Yeah, it's managing expectations for many of these women, isn't it? And then, as you say, there's limited options potentially for improving things afterwards. So thanks very much, and stay with us. There are lots of questions pouring in on the chat, on the Q&A, not the chat, and so there'll be lots of time for more discussion at the end. So thanks, Sarah.
Thank you very much.
It's my pleasure next to introduce the proverbial person who needs no introduction in this context. Everyone knows you, Marie-Madeleine. It's fantastic to have you with us tonight. So for those of you who are perhaps marginally less familiar with Marie-Madeleine, she's a gynecologist, head of the gynecology research unit at UCL in Brussels. And she managed to balance clinical work and research since starting her medical degree back in 2000 with a PhD in ovarian tissue cryopreservation. She has many honors. She's past president of the International Society for Fertility Preservation, on which her research focuses, but also a lot of work in endometriosis and adenomyosis with over a couple of hundred peer-reviewed publications. And a remarkable honor to you last year, Marie-Madeleine, I understand, becoming a member of the Académie Royale Belge de Médecins. So fantastic, lovely to see that recognized. So tonight, Marie-Madeleine, we've asked you to discuss a recent paper, which is really quite a challenging and controversial topic. Fertility preservation before sterilizing treatment, cryopreservation of both ovaries to restore endocrine and reproductive functions. So we look forward to your thoughts on this topic. Thank you very much.
Thank you, Richard, for this nice introduction. Do you see the screen correctly?
Yes, all good. Thank you.
Perfect. So I have my mouse there. So indeed, it's a provocative paper, I would say, that I published together with Catherine Poirot from France, and then Nicolas Fourreur and Claudine Esper. And so the title is Cryopreservation of both ovaries to restore endocrine and reproductive functions. So first, as an introduction, we know that ovarian tissue cryopreservation followed by transplantation is an efficient fertility preservation technique. So our latest paper in Fertility, Sterility 2021 from 5 leading European centers concludes that the restoration of ovarian hormone function is about 90%, and the rate of and the live birth rate of at least one child is 30%. So it has its success, but in the context of that kind of fertility preservation, usually half an ovary or a whole ovary is removed, leaving the lab and the transplanter with a quite limited number of frozen ovarian fragments. And of course, the priority to keep all fragments for reproductive purposes, because that's the aim, the final aim of the technique. But the question was, is there a possibility to restore both endocrine and reproductive functions within different time frames, and of course after several reimplantations? Because there is a major risk of severe alterations to the ovary that is left behind. So there we arrive to that question: is it feasible to propose removal of both ovaries before highly gonadotoxic treatment? Indeed, this would leave the doctor with more availability tissue to transplant, and for the patient, it would be able to restore both ovarian functions. But, of course, it's provocative. There are questions. But is it ethically and legally feasible, and are there any medical benefits? So the plan of my talk will be to discuss these ethical aspects, these legal aspects, and these medical aspects. So these three aspects were discussed in detail in our article by all of the co-authors that you see here. So about the ethical aspects, interviews were done with those most directly concerned by the topic, which means 14 multidisciplinary healthcare professionals from hematologists, oncologists, gynecologists, reproductive ones, and 3 patients. So those 3 patients had each 2 children after ovarian tissue transplantation. Then multidisciplinary discussions were led with 15 individuals specifically trained in clinical ethics, comprising doctors, paramedics, psychologists, philosophers, jurists, and sociologists. And so the questions that were raised during the interviews and discussion were these 4: over-medicalization, symbolic dimension of taking away 2 ovaries, hormone function, and information. These are the four topics we will discuss about the ethical aspects. So first, over-medicalization. Well, those arguing 1, rather 2, cryopreserved ovaries are giving these arguments. Given the nature of the treatment, taking 2 rather than 1 would be an additional technical medical procedure. Moreover, ovarian tissue transplantation is not always possible or effective. This is for cervical cancer, for instance. There is a low return rate, I would say with maximum 15%. And if we speak about hormone therapy, other alternative exists, like external hormone intake. And if you consider what this means for medicine, well, it could be an intention, it is causing intentionally ovarian failure, and it could be an excessive control by the doctor, which is not justified by his role of treating. But why not 2? The others would say, well, about the technical aspect, if you are there in the belly to take 1 ovary, it's not so complicated to take the other one also. And it would make possible to avoid HRT later on with giving fewer drugs to these patients. The role of medicine, well, could give a long-term impact on comfort and quality of life, and it will enhance patient autonomy, and also they appreciate the no need for pills. So that was over-medicalization. What about the symbolic dimension? Because we speak about ovaries. Well, of course, 1 rather than 2, because it affects the gonads. This is really precious. And if we take 2 ovaries away, well, then we are there with a notion of castration among professionals. And then they compare between men and women. It's not really the same because inside and outside, but still, these are gonads. And it affects a person's integrity, both from a physical point of view and a symbolic point of view. Why not 2? Well, in fact, none of the patients we met saw this as a castration or a mutilation. These patients perceived the process rather as more natural. About hormone function, 1 rather than 2. Well, hormone function issues are secondary. Priority is given to the disease, of course. We treat cancer first, fertility later, and endocrine function is the last consideration. Why not 2? Well, there is an essential role of endocrine function for health. Better physical health with your own hormones, and HRT might be considered as intrusive. And also there is an essential role of endocrine function in terms of quality of life for both sexual health and comfort and femininity. And so one quote of these patients was, taking 2 ovaries for preservation of natural hormone function is just as acceptable as for fertility preservation in terms of long-term impacts on comfort and quality of life. So the last point that came out of this discussion about ethical aspects is information and decision-making. So in the group for rather 1 than 2, free and informed consent may be complex for that topic, and also is usually guided by the information that is provided from both sides, patient and doctor. And the informed consent might be tricky in minors. Why not 2? Well, there is a woman's right to decide for herself. This is supported by patients and professionals alike. So to pick up some conclusions about the ethical aspects, we would say about beneficence, so doing good. Fertility preservation relates to the future of these cancer patients, and it gives them hope. About non-maleficence, so not doing bad, none of the patients mentioned castration, and preservation of a natural endocrine function is acceptable by the patients. Respect for autonomy is supported by both patients and professionals, and the aspect of justice, well, broader societal discussion are needed because women must have their say. We go on to the next point. What about the legal aspect? Are there any legal arguments against removing both ovaries in women about to undergo highly gonadotoxic treatment? Well, therefore, because the co-authors are all French, we analyzed the French law on bioethics that was revised in August 2021, and this law was widened. This law widened the field of conservation of gametes and germinal tissues from restoration of fertility to now restoring hormonal function. So going back to our question, are there any legal arguments against removing both? Well, castration, no, as there is a medical objective and a specific purpose, so it cannot consider it as a castration by the law. Is it a sterilization? No, because in the law, sterilization involves the fallopian tube. And it can be considered akin to uterus transplant, as the frozen ovaries will be used for reimplantation. To end with the legal aspects, there are some conditions. And so the law provides these 4 conditions. Adequate information should be given to the patient. Of course, we need to obtain consent. About the age, well, at least in France, up to 43 years if it is for medically assisted procreation, and up to 49 years if it is for hormone function. And point 4, patients must be regularly asked about the fate of their stored tissue. So I will end the third topic by the medical aspects of this hypothesis. So in case of very highly gonadotoxic treatments, is it medically indicated or preferable to remove both ovaries? Therefore, I will go back to one recent article which discusses premature ovarian insufficiency after bone marrow transplantation. It was published in Transplant Cellular Therapy in 2023 by a French team, and it analyzed the ovarian function and spontaneous pregnancy after hematopoietic stem cell transplantation for leukemia before puberty. So one slide to explain what is discussed, and especially rather the results of that article. Well, there were all childhood leukemia patients. The follow-up was 18 years after hematopoietic stem cell transplantation. 178 women were analyzed, and 60% of these women needed pubertal induction. So this leaves us with 40% who presented with spontaneous menarche, but 46% of these developed premature ovarian insufficiency within 5 years after the hematopoietic stem cell transplantation. To note is that all these women received a myeloablative conditioning treatment, so either total body irradiation or busulfan-based regimen. Another conclusion was that the older age at the time of hematopoietic stem cell transplantation, there was a significant risk factor for premature ovarian insufficiency. So let's look at that result. So if these patients underwent hematopoietic stem cell transplantation before the age of 4.8, well, more than 65% of these patients could have spontaneous menarche, and almost 50% did not present with POI at last evaluation. But if the hematopoietic stem cell transplantation occurred after the age of 10.9, more than 85% of these young patients did not have spontaneous menarche. So if we conclude for a patient after the age of 11 with hematopoietic stem cell transplantation, this leaves us with an 85% of failed endocrine function. Of course, if both ovaries are removed in these patients, well, this is a 100% of spontaneous endocrine function. But then, what we comment here and discuss is if both ovaries are removed but later reimplanted, well, we'll have a 90% recovery of endocrine function. As we discussed in the introduction, the rate of restoration of hormone function after ovarian tissue transplantation is about 90%, and the rate of live birth is 30%, which is markedly better than what we can expect after natural resumption in patients having to undergo highly gonadotoxic treatments. So, removing both ovaries gives a much better chance of hormone and reproductive restoration than leaving all the tissue in place. So indeed, with one ovary, we have a more limited number of frozen ovarian fragments. Priority is always kept for all the fragments for reproductive purposes, but with 2 ovaries frozen, there would be enough tissue to consider using it for endocrine purposes too. And in fact, this has the proof of concept and the feasibility, the technical feasibility and result has already been done if we consider endocrine purposes after ovarian tissue transplantation. So hormonal function can be restored in children to induce puberty. This was presented in The Lancet in 2012 by the team of Catherine Poirot, and also discussed by the Danish team of Klaus Andersen in the European Journal of Cancer in 2013. And if we consider the other period of the life to restore hormonal function, then we have the menopause symptoms. And you see that RBM Online is quite keen in producing these provocative articles, because in 2015, the team of Andersen discussed a novel use of the ovarian follicular pool to postpone menopause and delay osteoporosis. And Donné and me, we discussed in 2018 natural hormone replacement therapy with a functioning ovary after the menopause, dream or reality. So from these 2 articles, I took the cartoons, and the conclusion would be that indeed ovarian tissue cryopreservation for purposes other than restoring fertility would require further clinical investigation. and this might be the future, I will conclude the whole talk with, in case of very highly gonadotoxic treatments, it might be preferable to remove both ovaries. From a reproductive function point of view, absolute priority is given to reproduction, especially with limited amounts of tissue. If we consider hormone balance, restoration throughout a woman's entire life would be possible if we have enough tissue frozen, with the possibility of puberty induction and menopause-related symptom relief. And there is a psychological well-being argument. If we consider the burden of taking daily medication, that would be eased with that procedure, and those girls would not feel different from their peers because they would have natural cycles. I thank you for your attention. Of course, I thank my co-authors of this paper from Paris, the research lab, and all my clinical colleagues and Professor Denet. Thank you.
Thank you very much, Madeleine. Fantastic presentation and a really interesting, challenging question that I'm sure is going to be debated around the globe over coming years, and we'll see whether anyone takes your bait and takes it up. We've got a whole bunch of questions. Can I just start the ball rolling? I mean, a lot of it really hangs on this business of identification of the most gonadotoxic therapies, isn't it? Because we've all seen women have pregnancies despite having what we thought and were told by their oncologists were going to be sterilizing treatments. So it's a really, to go in and prevent that chance is an important consideration in such patients, isn't it?
Of course, that's the whole problematic. So it's the indication. So we need to be quite sure that the patient would be menopause after that treatment. I had a bunch of articles that I could have put there from the literature. Of course, the patients that we consider for that technique would be those with bone marrow transplantation, as definitely these are reported to have a very high risk of premature menopause after bone marrow transplantation.
Great. Thanks very much indeed. I'm sure there'll be more questions in a minute. Laura, do you want to kick off the general Q&A session?
Thank you, Richard. Thank you, Marie-Madeleine. I think these provocative questions are so important to the field. I mean, really to try to think outside the box is so important to help more and more patients to have the best treatment and the best fertility future. I would like to go back to Sarah. If Sarah is still there, just to be a little bit provocative. You were talking about when old is too old to cryopreserve. Now I would like to ask the opposite question. When is young is too young to go through fertility preservation? I mean, we know perfectly how the age is affecting oocyte quality, but we know also that we have a range of age where the oocyte quality remains good. So could you comment on that? When is too young? A 20 years old girl or 25 years old young woman comes to your center for elective fertility preservation? What would you suggest?
It's a good question. We're increasingly seeing a lot of women in their 20s in New York who are coming in interested in fertility preservation. A lot of them, because they have it covered by their current employer. So, now often we'll get patients who come in at 23 or 24 and say, I have coverage now. I'm planning to leave my job in a year. I want to take advantage. And that can be, a hard question to answer. And, really now we're seeing that about 7% of our fertility preservation cycles are in women in their 20s, which is much higher than it's been historically. I think, it has to be a discussion with the patient about what their family building plan is. So, for example, if we have somebody who comes in at 25 and they're planning to deploy to the military, or if they know that they're going to become a surgeon and going to be in training for many years, that patient I would be more inclined to recommend fertility preservation as opposed to somebody who said, it's just due to lack of a partner. If I meet somebody in the next 2 to 3 years, I'd like to have children before I'm 30. For those patients, I typically would recommend coming back usually between 30 and 35, unless there is some kind of circumstance that would warrant it being done earlier, where they really know that they're not even going to start trying until after the age of 35. And if they know that they're not planning to start trying until after the age of 35, I do think it can make sense at a younger age. And of course, these patients also have to be counseled about the risks of the procedure, because I think that's something that a lot of them, don't understand when they come in for the initial consult, is that this is time consuming, and there are medical risks, especially if you're young and you have a high AMH and a high egg count. There is a risk of OHSS, and that needs to be something that's considered.
Thank you, Sarah.
Can I ask a question that's actually been asked on the Q&A that's, I think, appropriate for both Michael and Sarah, actually? Maybe start with you, Michael, but same question essentially. What are you going to do with all these eggs that no one's going to use or ultimately want? What sort of contract do you enter into with your patients over how long you're prepared to keep them?
Well, France is a fantastic country. There's nothing. Okay, we can keep, and everything's free for everybody. So they do not have to pay cancer, social egg freezing, nothing to pay, even for keeping everything frozen. So the only thing which is written in the law is that when the patient dies, we have to destroy the biological material that has been frozen. But that's it. So all patients, once they have frozen, they receive each year yearly a form just asking whether they want to keep everything for one more year, to destroy, or to give for research. But not giving for donation for other patients, but for sure in cancer patient, this is not this cannot be considered. But for donation for other patients, this is not in the law, and they have to ask for a special. They need to make a special demand for this. But on the basic form, it's destruction, keep for one more year, or give for research. That's it. So, and the limit, there is an age limit now, since the last bioethics laws, and the patient absolutely need to reuse their eggs before the age of 45.
45. Okay, so quite young, really. So a 46-year-old can't keep their eggs.
No.
Wow. I guess, Sarah, it'd be interesting. I guess you'll have a different perspective.
Yeah. So, there are a few different things that are done in the US. So first, there are storage fees, which typically are around $1,000 per year to keep the eggs in storage. So, many patients don't want to store their eggs indefinitely because of that storage fee. And then there's also a question for the fertility centers of what should be done when patients stop paying their storage fees. Because, it's tough to discard somebody's eggs, which are, material that can't be replaced. But if you can't get in touch with them and they're not paying storage fees, what do you do about that? So we, also do have in our consent forms before patients undergo the procedure, what would happen to their oocytes in the event of death, or the event that, we can't reach them, should they be discarded or donated to research, or inherited by another person. But it's a little bit more murky in terms of what should happen if they don't pay storage fees. A lot of centers in the US, will kind of transport them to a long-term storage facility that's off-site, but not destroy the eggs. We also do not have an upper age limit in the US of when patients can return to use their frozen eggs, which can be difficult in certain situations, because you have to balance, patient autonomy with patient safety, and potential risk to the mom and the baby of carrying a pregnancy at an older age. At our center, we typically have any patient who returns over the age of 45 do a consult with a maternal fetal medicine specialist before having a transfer, to go through the risks and make sure that their health is optimized. But we don't currently have an upper age limit. personally, kind of the oldest I've really seen patients returning are their mid-50s, but that can be very high risk depending on what their medical conditions are.
Thanks. Lara.
Yeah, I would like to come back to Marie-Madeleine. There is a very interesting question from Morocco. Do you take under consideration the maternal age, the age of the patient, when deciding to cryopreserve both ovaries or not? I mean, which seems quite logical in advanced maternal age, but in very young patient, do you have the same? Do you include the maternal age in your decision-making process?
In fact, well, first, we don't do it yet. It was rather a provocative comment. But the aim would be to be able to restore endocrine function. So to have, this includes the prepubertal patient who, when they are completely in poi, before their puberty, would need to go through the endocrine pediatrician and take some patches to induce slowly. It takes about 2 years to induce puberty by hormonal intake for these young girls. So the aim would be just to transplant the tissue in order to avoid all that hormone intake and drug and pills, which reminds the patient every day that she has been ill. So yes, the purpose is to do it at a very young age for those very young girls who would have to undergo bone marrow transplantation. Okay, the older patient could undergo that too, but then the benefit is less also, because the content would be less, and yes, you have only one part of the endocrine hormonal function, and as you have seen, transplantation is not allowed after the age of 45 for reproductive purposes and 49 for hormone purposes.
And can you just explain better how the transplant works? There is a question saying,
yes, if we take both ovaries away, we don't have an ovary to transplant the tissue back. That's
exactly
true. So the idea is to take only the ovaries away and not the tubes, which would leave you with the fossetta ovarica just below the tubes. You have there some place to replace the fragments, which is that is a place where we do the transplantation nowadays, even for patients having one ovary left. I use the remaining ovary for the transplantation fragments, but of course that remaining ovary is very small. So I can put only 4 or 5 fragments there, and the other fragments are put in the window below the tube. And it works very well, and it's in fact very easy to do that kind of transplantation.
Thank you for this technical specification. I think it was very important.
Can I come back to breast cancer, Michael? We got a question about what are your thoughts about integrating breast cancer prognostic data in individualizing fertility preservation and decision-making, especially for patients with limited time before starting treatments?
Well, I think I think this is not absolutely an issue, except for patients with general metastasis. In this context, fertility preservation should, from my point of view, not be considered. Surrogacy is not allowed in France, and is probably something which is very debatable anyway. We can discuss it further if you want. But for those patients with general metastasis will never have the possibility to carry a pregnancy. So in this situation, well, freezing eggs is probably not a good option. But in all other cases, whatever the local type of cancer, the possibility of node invasion, well, should not be a contraindication to stimulation. And most of the time we have time to do it, except if the oncologist do not refer the patient sufficiently early in the pathway. But if they're immediately referred for oncofertility counseling just after the diagnosis, then we have time, because time for the patient to be prepared for chemotherapy, even neoadjuvant chemotherapy. Most of the time nothing is done between 10-12 days. So we have sufficient time for doing whatever we want. But most of the time it will be one single ovarian stimulation, and that's the reason why we have to be a little bit pushy in terms of dosage.
Yeah, great, thanks. And can I just follow up with a question from Jamal Fikri from Morocco? Can you provide some information about the BRCA mutations in your study, knowing that status might have a detrimental impact on ovarian reserve?
Well, we did a couple of studies on this population, and well, as you know, in the literature, there's data relatively, there's discrepancies, and it's debatable whether BRCA, especially BRCA1 mutation carrier, have lower ovarian reserve markers. So some papers mention that it could have an impact on in lowering AMH and antral follicle count, but some other studies failed to observe any difference between BRCA mutated patient and controls. And in our population, there was no difference between women mutated or non-mutated, and we considered those patients exactly the same.
Great, and would you consider them for egg donation?
Sorry?
A patient with a family history of breast cancer, would you consider them for egg donation, or it should be an excluding criteria?
It is an excluding criteria in our country.
So, Richard, if you allow me, I would come back to Sarah for a more technical question. I'm just summarizing different questions, talking about a patient asking for fertility preservation, are older in age, come with low ovarian reserve. So do we have new technology, algorithm or AI applied to oocyte to be able to better predict the quality of this oocyte and the survival rate? Are you aware about this kind of new technology applied for oocyte cryopreservation?
No, I don't know about any, technologies that are currently implemented to evaluate oocyte quality at the time the eggs are freezing. And I think that's one of the things that's most difficult in counseling patients is that you don't know if a patient who froze 5 eggs, are those 5 eggs good quality? Are they poor quality? What is actually the chance? There's really no personalized information that we're able to give patients at this time. All we can really give is an average based on other patients their age who froze a similar number of oocytes.
Yeah, but there are some tools available on the market, but the AUC is not more than 0.7. So the clinical efficiency of this kind of prediction has to be really balanced. But I think we have to work on that to have more data, more objective data to say to the patient. Now we just put all the patient with the same number of eggs and same age in the same prognosis factor, but probably we can learn much more by looking to the oocyte and better predict the adequate number of oocyte to be cryopreserved for the different patient population.
Definitely,
so this is a challenge really in embryology today. Before there were no oocyte cryopreservation, no need to look to the oocyte. We were just waiting the embryo, and now there is a new gap in knowledge, which is to predict what the oocyte. We know that most of the quality of the embryo depends on the oocyte quality, so we should be able to improve this prediction to better consult the patient for fertility preservation.
Can I come back for perhaps a last question to yourself, Marie-Madeleine? Because you highlighted how important this consideration might be for children, for young girls. Are you happy to extrapolate the results from adult women having ovarian tissue stored and replaced to children? Because almost all the data are from women who had ovaries stored in adulthood, and you quoted data on that. Which is it's far from always successful, isn't it? I mean, 25 to 30% of those women will successfully have a baby. Do you think we can extrapolate that to 10 or 11-year-olds?
That's an excellent question indeed. So most of the data are coming from adult patients. More and more young people, they grow up, and so they come back to benefit from the technique. So it has been proven that it works for reproductive function if you transplant an ovary that was frozen in prepubertal status. It was still questionable before because the concept of mature tissue had not been done. But this happened. It was in the UK, the first lady. So the baby is well. And as I showed, for puberty induction, it works also. So yes, I am.
Very bullish, positive comments to finish the session on. Thank you, Marie-Madeleine.
Yeah, thank you. I really would like to thank you all to have been part of this fantastic webinar. I've learned a lot from different perspectives. So I would like to thank first my co-host, Professor Richard Anderson, but also our presenters, or Professor Michaël Grynberg, Sarah Cascante, and Marie-Madeleine Dolmans. It was really a pleasure to be here with you. I would like also to mention again the special issue on RBMO for the 25th anniversary. It will be out very soon. I would like finally to thank all of the people participating, more than 400. I saw 400 and something, so it's from all around the world. It's really an honor to have been part of this webinar. Next RBMO Live will be June the 10th. And we are going also to announce the winners of our annual Robert Edwards Prize Paper Award. Follow the journal on our social media channel and mailing list for news, updates, and registration details. I hope to see you soon in other occasion.
Thanks very much, Lara, and thanks again to our three speakers for great talks and some great discussions afterwards coming from our fantastic audience as well. So yeah, tune in next time for the next one. Also, my thanks to, of course, to the organisers at i3 who've done a great job in pulling this together and making this such a nice session. So that's Jacques Cohen, Peter Nagy, Marianne Cezate, Thomas Elliott, Fran Farley, Violetta Sora, and Giles Palmer, of course. So thank you all for a great evening and look forward to seeing you again at the next RBMO i3 webinar. Good night, everybody.
Thank you. Good day, good evening, and good night, all.